So coming to minimal access surgery instruments. Laparoscopic surgery, known as minimal invasive or keyhole surgery, depends on various factors. First is image production. That is, it's important to have a good camera which gives us a clear view. So in this, we have either a 0-degree camera or a 30-degree camera. Secondly, we need to create a pneumoperitoneum. That is, we have to fill up the abdomen with gas so that we have a working space and we are able to visualize the organs more clearly. Most commonly used is carbon dioxide because it is it is easily available, it is cheap and non-combustible and provides a better visibility. Laparoscopic instruments are specialized tools which are designed to be inserted through the small keyhole, and they help in surgical procedures. They can be graspers, scissors, dissectors, and manipulators which help in cutting, suturing, and cautery. So, an appropriate hardware and instrument is very important. It is important to have a good technician who can take care of all the instruments. Okay. Specialized operating room for the laparoscopic interventions, sufficient reserve of instruments to address any malfunction. So if a grasper has broken or if a cautery is not working, we should have a spare cautery for us to work. Facilities for intraoperative imaging. For example, if we find something which was not preoperatively checked and we need to see that, so we should have maybe a C-arm in the OT which can help us to do it better. Laparoscopic surgical tools are visual devices, devices for establishing or maintaining space, access instruments, surgical instruments, power instruments, that is cautery, tissue closure and hemostatic tools which help us to suture the tissues, and miscellaneous tools. Now, optical devices include the telescope. Telescope is basically a surgical stainless steel tube, okay, which has inside it has a precise alignment of the glass lenses and spacers which give us a magnified view of the tissues. It can be a 0-degree camera or a 30-degree camera. 0-degree provides a vision in that particular area where the camera is focusing. 30-degree can be changed to provide view on the sides as well. So that also depends on the surgeon's comfort, whether they are comfortable with 0-degree or 30-degree, and that is variable with everybody. Most of the surgeons use 0-degree, but the gynecologists prefer to use 30-degree. The cameras can be 10 millimeter, 5 millimeter, or they can also be needle scopes like 2 to 3 millimeter. I will be showing you the real life demonstration of the cameras, the types which we use in the OT in the upcoming lectures. So this picture tells us about the camera, the scope. This is the area where the light has to be fixed. This is the area where the light is fixed, okay. This is the part where we attach the camera that goes to the monitor. This is the full scope. So half of it goes in the patient's abdomen, and this tip determines whether it is a 0-degree or a 30-degree lens. So if this slant, you can see that mostly is a 30-degree. If it is straight, then mostly it is a 0-degree scope. So this is just a magnified view. This shows us 0-degree means it will only have a view in this particular area. 30-degree will give a view in this area. That is, if we move the light cable, we are able to see maybe 90-degree from one side and 90-degree from the other side. Okay. This basically is a high intensity xenon, mercury or halogen lamp delivered via the fiber optic bundle, and this is where the light is attached. Light cable can be of two types. It can be a fiber optic light cable, or it can be a fluid cable which transmits light and completes the spectrum but more rigid. So this is a fiber optic light cable which mostly we use, and this is a fluid light cable. Video camera, the basis of the laparoscopic camera is a solid state silicon computer chip or a CCD, charge coupled device. The resolution or clarity of the image depends upon the number of pixels and the light receptors on the chip. Standard camera in the laparoscopic procedures is 2,50,000 to 3,80,000 pixels. So this camera which we use is basically, this part is the one which is attached to the scope which goes in the abdomen. This is the camera which from here is attached to the monitor. So once we fix it, we do a white balancing, then we focus it using these. So this is the focusing area which we have to move, and then we are able to get a clearer picture, and then we see inside. So this is the tower which we use in a laparoscopic OT. Here we put a monitor on which we are able to see the structures, This is the light insufflator. I mean, not the light, sorry, the gas insufflator, which shows us the preset pressure and what is the pressure actually when we go inside. This is the light source. This mostly is the harmonic machine which we put. So basically this has various shelves in which we can put all our machines, and this can be transported from one OT to the other. So high resolution video monitors are required for suitable reproduction of the endoscopic image. 3-chip cameras require monitors with 700 line resolution, realize improved resolution of the extra chip. Video printers, sometimes DVD recorders also can be used to record the surgery, or if the patient wants a CD, we can give them. So coming to equipments for creating and maintaining the laparoscopic surgery domain. So in this is a gas insufflator. So we use carbon dioxide most of the times. Creation of the working space in the abdominal cavity is done by insufflating carbon dioxide. This is the preset pressure, 12 millimeter mercury, and this is the actual pressure in the patient's abdomen. So this is the flow rate, this is the amount of gas which has gone inside. When we start insufflating, this mark goes up to 12. When it reaches 12, the insufflation will stop. At any time, if there's any leak from the abdomen, more of the gas goes inside. This preset pressure can go up to 12 to 15. Okay, so basically that is the maximum pressure which we use, that does not have any harm on the lungs, because in the gynecological surgeries we have to keep a head low position in which the patient's lungs get compressed to a certain extent. So more than 15 pressure is usually not allowed. The flow rate is about 20 millimeters and the about 20 liters per minute. And why do we use carbon dioxide most commonly? Because it has a low cost, it has a rapid reabsorption, it is low toxic to the peritoneal tissues, it inhibits combustion. Because we have to use cautery inside the abdomen, so we cannot use any gas which can burst, I mean which can get inflamed with the cautery. Okay. Now there also have been some researches on gasless laparoscopy. That is a theoretical advantage in some high-risk patients with compromised cardiorespiratory function. So whenever we do a head-low position for a patient in the OT, the anesthetist keeps telling us, bas karo, bas karo. Why? Because the more we do a head-low posture for the patient, lungs are compressed, the heart is compressed, especially if the patient is obese or old, then the heart rate and the respiratory rate, the SpO2 gets affected. Okay. So in a few cases, gasless surgeries can be done, but this is more of a theoretical thing than practical. Now, instruments access for the Viries needle. Viries needle basically, so this needle works on the principle of spring action. That is, it has sharp edge. This one is the sharp edge and this is the blunt edge. So this edge usually is out. When we push it, this blunt edge goes inside and the sharp edge comes out. It pierces the tissue and the needle goes inside. This is the first thing we put inside the tummy of the patient to create a pneumoperitoneum. What is the advantage of the spring action? When there is resistance, the sharp edge will push it and the needle goes inside. As soon as the tough tissues are pierced, the spring action allows this blunt edge to come out. So when the blunt edge is out, inside the chances of bowel injury is very less. Okay. This Viries needle usually is made of steel. We also have now plastic Viries needles which are used, and through this we are able to put carbon dioxide into the patient's abdomen. So Viries needle is designed to create a pneumoperitoneum prior to the insertion of a trocar in a closed fashion. It consists of outer sharp cutting edge and inner blunt spring loaded obturator. Also we can use a Hassan's technique, that is open technique, in which we make a cut in the abdomen and we keep cutting every layer and we go inside under vision. Another advantage is of the Hassan's technique is we of course know what we are cutting and there is very minimal chance of any bowel injury, because sometimes there can be some adhesions of the bowel in the area where we are going which we don't know. Even in the patients with no surgeries before, there can be abdominal adhesions and you can inadvertently go into a vital structure. So then it becomes a problem for the patient. Optical trocars are also called Visiport. So optical trocars we'll be showing you in the upcoming lectures. Basically, we have a transparent port which we put inside the patient's abdomen. Through this, we put the camera and slowly with screwing action, we go inside the tummy, visualizing every layer what we are going through. So we have an idea when the fat is coming, when the rectus sheath is coming, when the rectus muscle is coming, and then when we go inside, we have an idea whether we are going into a visceral structure or not. Okay. So optical trocars are also a good technique when we are expecting additions or when the patient is fat. So this basically is a common trocar and cannula which we use. This is the outer part is the cannula and the inner part has a sharp trocar in it which helps us to go inside. Operative instruments. So trocars are available in various diameters and sizes. They can be 10 millimeter, 5 millimeter, and they can be bladed or non-bladed, and bladed are the ones which are shielded and unshielded type. So this is the visiport which I was talking about. Basically, this part is transparent. This is a transparent part. Okay. So when we put it in the patient's abdomen, we put the camera from here and we are able to see all the layers through this transparent area and we know what we are cutting. So this becomes an added advantage to enter. So these are the various types of the trocar tips, okay, graspers. Now we need to hold the structures in the laparoscopic surgery. We need to maybe hold the bowel, hold the rectus sheath, hold a cyst or hold the uterus. So we should know what instruments to use for what structures. So we have the bullet nose grasper and the dorsi-intestinal fenestrated grasper. Intestine is a very delicate structure which should not get injured. So we use the atraumatic grasping instruments to hold the intestines so that they don't get injured. So this instrument you can see the bullet nose grasper, these fine serrations are there, and this is the dorsi-intestinal grasper, these also fine serrations are there. So these serrations basically they are atraumatic, they don't allow the intestine to get crushed, and we can retract the bowel using these instruments. We can also hold the rectum and the small bowel with these instruments. Hunter bowel grasper has 2 rows of atraumatic serrations. The jaw comes in different lengths depending on the needs of surgical procedure. Crocodile grasper also is there with contoured jaws and tissue herniation, and there's a raptor grasper. So basically in general we use a term grasper which the technician and the sister also understand, that is an atraumatic instrument which helps us to hold especially the bowel. Okay. So these graspers again you can see which will be further discussed in the upcoming classes. This is the raptor grasper, this is the triangular endoflexed retractor more used by the surgeons. Maryland instrument is a very important instrument which helps us to hold the firm tissues. For example, when we are doing an ovarian cystectomy, in that we need to hold the cyst, we need to pull it away from the normal ovarian tissue. We have to make sure that we don't slip, the tissue doesn't slip repeatedly. So the Maryland grasper helps us in that. Bipolar dissector consists of 4 pieces. When assembled, it should be disassembled during sterilization. So bipolar basically is an instrument which helps us to cauterize whenever there's any bleeding. Scissors, there are a variety of scissors. Some are used only for the tissues, some are used to cut the sutures. So depending on what kind of edge they have, this scissor mostly we use to cut the tissues, and this kind of scissor we mostly use to cut the sutures. For further atraumatic kind of instruments, we have another instrument called the Babcock. In the open surgeries also we use a Babcock instrument, that is to hold the bladder or the tubes, the fallopian tubes that are very delicate structures which should not be injured. So in the laparoscopic also we have the endolung clamp and the endo-Babcock. It is used, the Babcock instrument is used in delicate surgeries during hysterectomies as well. Energy sources. Now, energy source forms a very important part of laparoscopic surgery because in an open hysterectomy, when we are suturing every pedicle, in the laparoscopic surgery, we are cauterizing every pedicle. So, a good electrosurgical instrument is important for us to complete the surgery to ensure that there is no bleeding and there is no chance of secondary hemorrhage. Electrosurgery cautery refers to the direct current where electrosurgery uses alternative current. During electrocautery, current does not enter the patient's body, only the heated wires come in contact with the tissue. And electrosurgery, patient is included in the circuit and the current enters. So we have 2 kinds of instrument, bipolar and monopolar. In bipolar, between the jaws of the bipolar only, the current gets transmitted. Whatever we have held, if we are holding a uterine artery and we are doing a bipolar, then only the artery gets cauterized. Okay, the two lines of forceps perform active and return electrode functions. Only the tissue which is grasped in the forceps gets cauterized. Coming to monopolar, the active electrode is the wound and the patient's return electrode is attached somewhere else in the patient. That is, we put a cautery plate maybe on the thigh or on the back, and the current must flow through the patient to the patient's return electrode to complete the circuit. Now, the difference between monopolar and bipolar is that bipolar has more precise action. Monopolar has more of charring effect. Monopolar is a very dangerous instrument because if it touches the bowel gets injured and that area gets really affected. Bipolar also can affect the bowel, but the chances of injury are less because the current flows between the two forceps jaws only. Secondly, it's also very important for us to understand about the lateral spread. In any kind of cautery when we are using, we need to know what is the lateral spread of that particular instrument and where we are using it. If we are using it in the lateral pelvic wall where we have the vital structures like the ureter, so if we are using a monopolar in that area, because of the lateral spread of current, the vascularity of the ureter can get affected and it can get affected. It can get necrosed. But if we use the bipolar maybe or the harmonic or the ligashore, which I'll come to, then the chances of lateral spread are very less. So they can be used near the vital structure. So safety considerations during electrosurgical laparoscopic surgery involve direct coupling, capacitive coupling, and insulation failure. Most potential problems which can be avoided by inspecting the insulation carefully, use lowest possible power setting, because in the lowest possible power setting, coagulation is better and the tissue gets completely coagulated and then it gets cut. We use low voltage waveforms to cut, use a brief intermittent activation versus prolonged activation. We do not activate in close proximity or direct contact with another instrument. That is, if we have held the tissue with our grasper, then the bipolar should not touch that instrument. Otherwise, there can be short circuit or the bipolar can get spoiled. Using bipolar electrosurgery only when appropriate. Wherever possible, if we need, we can do a blunt dissection without using cautery. So we should know where we can use the cautery. Then select all the metal cannula systems as the safest choice. Do not use hybrid cannula systems with mixed metal with plastic. There can be some heat transmission which can affect the plastic. So we should know what kind of instruments to use. Utilize the available technology like tissue response generator or reduce the capacitive coupling or an active electrode monitoring system to eliminate the concerns about insulation failure and capacitive coupling. Argon enhanced electrosurgery incorporates a stream of argon gas to improve the surgical effectiveness of the electrosurgical current. Argon gas is inert, non-combustible, making it a safe medium through which the current can pass. Ultrasonic energy. Now, the advent of harmonic scalpel has changed our outlook towards hysterectomy, cystectomy, various gynecological and surgical techniques. So basically this uses an ultrasonic technology, which is a unique energy that allows cutting and coagulation together. Before this, what we used to do is, we used to first coagulate with the bipolar, take it out, then cut it with the scissors. But the harmonic does both the functions simultaneously. It coagulates the tissue and it cuts as well. So this saves our time. This has minimal lateral spread. Cutting and coagulation by using lower temperature than those by the electrosurgery or lasers. So the chances of heat generation, the chances of smoke which is produced, which can hamper our visibility, is lower in the cases of harmonic scalpel. Coagulation occurs by means of protein denaturation when the blade vibrating at 55,000 Hz couples with the protein, denaturing it to form a coagulum and seals the small vessels. It offers greater precision in tight spaces near the vital structures. Fewer instrument changes are needed, less tissue charring, desiccation, and visibility is also improved. If we use a monopolar, a lot of smoke is produced, which has to be cleared in between every time. But the chances of the smoke being formed with the harmonic scalpel is very less. So harmonic scalpel basically has a machine. This is the machine which generates the ultrasonic current. This is the instrument, okay? and the tip looks like this. So this tip basically has an active blade, and this is the inactive blade. This active blade is the one which, if it touches any tissue, it is going to burn. So this should be only towards the tissue which has to be cut, and this can be on the other side, like towards the bowel, so that even if it touches, of course we should keep the bowel as away from the surgical side as possible, but even if it touches, then the chance of injury is very less. Okay. Power setting: the harmonic scalpel has 5 power levels. It has a minimum setting and a maximum setting. In the minimum setting, we usually keep it at 2, and the maximum setting we keep it at 5. So with the minimum we coagulate, and with the maximum we can cut. So the slower we coagulate, the better, so that the chances of complete coagulation are there. If we do a quick coagulation, sometimes after 2 minutes that particular pedicle can start bleeding. Instruments for tissue approximation and hemostasis. Laparoscopic ligating suture delivery system. So what we usually use is, we take a needle holder, we take a suture, we usually use the V-lock in gynecological surgeries or the Vicryl number 1. We put it inside and we start suturing. There are few sutures which are available which have pre-tied sliding knots with a loop which is available with the nylon carrier rod to ligate the stump-like structures or the tubular structures, that is the Sergi tie. Suture is looped around the structure to be ligated, and knot is slid down close to the loop. It is also useful in appendicectomy. So this is the knot pusher, and this is the Sergi tie. Okay. Needle drivers. Endostitch is a 10 mm disposable suturing device. The needle features a sharp tapering point at each end with suture attachment at the center of the needle. The double end needle is passed between the 2 jaws of the suturing device. Its advantage includes easy introduction, atraumatic needle manipulation, good security, and easy accurate needle placement. So this is the needle holder, which usually looks like this at the tip. It has small blades which have serrations which can hold the needle, and that helps us to do this movement when we are trying to take a suture. And this is an endo stitch. Clip applicators. Sometimes when we are dissecting deep in the pelvis, like when we are near the major vessels or when we are near the ureter, where we cannot have too much of space, and where taking a stitch or taking a cautery can be dangerous to the vital structures, we use the clip applicators. Clips basically are small staple-like clips which are applied on a knee, on a bleeding vessel to close the bleeding. So basically is a primary modality for ligating the blood vessels and other tubular structures. Disposable clip appliers contain up to 20 clips, and the reusable clip appliers carry 1 clip at a time. Clips are made of titanium, though the absorbable clips are also available. So this is the clip applicator which is used in laparoscopy. Here we put the clip, okay, and we put it inside, hold the structure where the clip is to be applied, and press the jaws, and then that clip gets pressed on that particular tissue. Now coming to mechanical stapling instruments, laparoscopic staplers are modification of the stapler device in the open surgery, and these staplers mostly are used by the bowel surgeons for dissection and reanastomosis of the bowel. A range of staple length, that is 2.5 to 3.8 millimeters, is available depending on the thickness of the tissue to be applied. Aspiration and irrigation probes, very important. We should have a suction and irrigation system in the surgery. Whenever there's bleeding, there's any fluid collection, we need to suck it out. Plus, we need to put some fluid and check about the bleeding. So these are essential procedures for laparoscopic surgery in order to maintain a clear field. Irrigation and aspiration channels can be incorporated into surgical instruments, but working channels are small and subject to repeat clogging, especially when we are dealing with a dermoid cyst. Dermoid cyst, like I had explained in my ovarian cyst lecture, they contain sebaceous material and maybe tooth or cartilage or hair which can block the suction tubes. So we need to keep changing the suction tubes. Sometimes we can also use a 10 millimeter suction, especially in the cases of ectopic surgeries. Ectopic pregnancy, if it is ruptured, there's a lot of blood and clots inside which are not able to suck by the 5 millimeter suction. So we use a bigger suction in that. So this is the suction irrigation system, and this is another modification. Now coming to hand-assisted laparoscopic surgery, hand-assisted hand access device is intended to improve the extracorporeal extension of the pneumoperitoneum and the abdominal access for the surgeon during laparoscopic surgery. It is indicated for use in laparoscopic procedures where the entry of surgeon's hand may facilitate the procedure for extraction of large specimens. It has application in colorectal, urological, and general surgical procedures. So, coming to organ extraction devices. Now, many times, suppose we are removing an ovarian cyst. We are not sure whether it can be malignant or not, despite our doing all the possible tests in the preoperative period, especially when we are dealing with a postmenopausal lady. So, we don't want any spillage, so that if it's a cancer, it should not get upstaged. So, what we use is, we use an endo bag. Endo bag basically is a plastic sterile bag which is put inside the patient's abdomen. The specimen is put in the endo bag. So suppose this is the cyst which we have excised intact and it has not got ruptured. We put the cyst in the bag. Okay. Then we pull this thread from here and we pull it back so that the mouth of this bag closes and the cyst is here inside. If it is a very big cyst, we can put a suction directly here and rupture it and suck it out in the bag itself. But if it is not very big, then this is the skin hole where we have put this endo bag through. We can pull it out and slowly using an artery forceps, we can take out the cyst in piecemeal. So this instrument is very important for us, especially preventing any spillage during the surgery. Coming to tissue morcellators, especially when we are doing fibroid surgeries, we have big fibroids which we have removed through myomectomy. Now, suppose the fibroid is this big. It cannot come out through this big incision. So what do? We use a morcellator. Morcellator is an instrument which cuts the fibroid into long, thin strips, which can come out from the 1 centimeter cut, which we have made on the skin. Because fibroid, there is no other place to take it out. Okay. So morcellators help in removing large solid tissues, and but the one thing which we need to take care of is that the morcellators are really invasive. They can cut through any tissue which comes in their way. So we have to be very careful while using them. Bowel injury can happen if we are not careful. Space creators, balloon dissectors in space dissectors with functions where when the saline or air is instilled into the pre-shaped balloon inserted. These are used for laparoscopic extraperitoneal surgeries like hernia, endoscopic neck surgery, subfacial, endoscopic ligation of the perforators, or the retroperitoneal surgeries. Thank you for your patient hearing. I am Dr. Nidhi Jain, obstetrician and gynecologist. Stay tuned for the further lectures. Thank you.